they're in. I can't see them on my screen, but I guess they're in. So good afternoon, good evening, good morning for some of you. We're excited to have you this evening for this particular session. We are going to be looking at palliative care policy, really looking at an example from Kenya, because Kenya launched its palliative care policy last year in October. And then we will have Makilan Tieno, who is the Executive Director of Kenya Hospital and Palliative Care Session, who will present on the process in Kenya, how it came about. And then Dr. Manuel Lurica, who is the Executive Director of the African Palliative Care Session, will talk about implementing the policies, and also just an experience of Africa, because APCA has been behind driving other countries in Africa, to develop palliative care policies. So for Kenya, I was involved from the very beginning. You can see my colleague, Dr. Esther Mwinga, was also very involved in our Kenya palliative care policy. Usually the WHO, I'll just share, I don't know if I'm allowed to share. I'll share one slide only. WHO has this recommendation: if you want to start a palliative care service, or if you want to have a palliative care service, this is what you should do. We should look at different aspects from a public health approach. We should look at policy, drug availability, education, and implementation. So some countries might start with a policy or start with whatever, but in Kenya, we found it was very difficult to start with a policy because we're talking about something people were not understanding, including even our Ministry of Health did not really understand what palliative care is. So we started to focus on other aspects of this public health approach. We did a lot of education. We did a lot of, we advocated for access to drugs for palliative care, especially oral morphine. And then we also did a lot of education of the public, policymakers, healthcare professionals, community health volunteers. And so because of what we were doing, we were also at the same time advocating for the government to integrate palliative care into the healthcare system. And so in 2010, we actually started working on implementation of palliative care into the integration of palliative care into the healthcare system, the public hospitals. We reached out to the mission hospitals and also the private hospitals. And so we were actually creating evidence that this palliative care works. And that's why we need a policy also, because a policy then makes it mandatory for the government to invest in it, to invest human resources, to invest finances into having palliative care services. So we managed to do a lot of stuff that finally, proved to be an evidence that we need palliative care integrated into a healthcare system, and also palliative care policy. I want to say thank you to African Palliative Care Session, Dr. Manuel and Makilan, who was working with APCA at that time, because they gave us the seed money to start holding meetings with the Ministry of Health. Ministry of Health put the policy under the National Cancer Control Program. It was just easier for them to find a host for the policy. And so we worked with the National Cancer Control Program to develop this policy in bringing in stakeholders. And Makilan will go into the process of how we did it. But finally, we did have a policy, and it was launched last year in October during the World Hospice and Palliative Care Day by the First Lady of Kenya. And so we were excited. We hope this policy will bring a change, although things have been happening, but we have the policy puts palliative care into a perspective where you're going to have resources, not just financial, but human resource, hospitals providing palliative care across the country for those in need. So with this short introduction, I'd like to introduce Makilan, who's the current Executive Director of Kenya Hospital and Palliative Care Session. She's a nurse by profession, a palliative care nurse as well. She has just completed her medical anthropology, so she should be very good in understanding human behavior. Why we are not picking up palliative care, because I saw in your slides there's a 3%. I think we are reaching more than 3%. So she will be presenting to us about the Kenya palliative care policy, and then after her we'll move to the next speaker before we get questions and answers. Makilan, karibu sana, you're most welcome.
Thank you so much, Dr. Zippy, my mentor, and thank you for summarizing the background to the policy. So it makes my work easier. So when in my presentation, I'll just go to the context of the palliative care policy. So allow me to share my screen. So just a summary of palliative care. What is palliative care? we know that palliative care, according to the WHO 2002 definition, it improves the quality of life of children and adults who are facing problems associated with life-threatening illnesses. And it also relieves suffering and pain through early identification, assessment, and treatment of pain and other problems. And I just want to stress that palliative care commences from diagnosis at the end of life and bereavement. And thus it should start and be provided at all levels of care to all life-threatening conditions. And in this case, we are talking in the context of cancer, which is also a life-threatening condition. So someone may ask, why palliative care? Why are we talking about palliative care today? So looking at the context, the global context, and even the African context, we find that about 56.2 million deaths occur worldwide, and most of them, about 45%, is because of serious health-related suffering. And to make it worse, that 80% of these people who die from serious health-related suffering, they're from developing regions, which is Kenya is part of. And in Kenya, we have approximately 15,000 adults and children who received palliative care in 2019. Well, the need is more than that, is more than even 150,000 people who need palliative care. So we find that the reach out is very, very little, is very, very small. So I want to bring to our attention this image that I got from the internet, IOM 2005, which looks at the cancer care trajectory. And as you can see, palliative care treatment is placed in one side as a part of the palliative care cancer care trajectory. But in the next slide, we'll see that palliative care is much more than the palliative treatment. Palliative treatment is part of palliative care, but palliative care starts from diagnosis, and it's taken throughout the trajectory. And we also want to note that hospices started providing care long time before even the policy was developed, as early as 1991 when Nairobi Hospice was started. And currently we have up to 18 hospices and more than 70 palliative care units that provide palliative care for people with cancer and other life-threatening conditions. So when I say that palliative care starts from diagnosis until end of life and bereavement, I want to look at this, the journey of someone who has a diagnosis, whether it's cancer or any other life-threatening condition. So at the beginning, there are concerns, spiritual concerns, someone asking, why me, why have I got this diagnosis? There's pain, physical and symptoms, there's social, maybe someone has a swelling, someone has a smell somewhere. And all these issues, as much as we're diagnosing and running around, doing all the scans and echo and all the PET scans and the rest, these are the issues also are there and they need to be addressed. And then throughout the journey of treatment and disease management, you find that, for example, someone undergoing chemotherapy, the hair will fall out, there's pain and there's vomiting, all those symptoms, they come in still through that process. We are treating, but these have to be addressed. And then towards the end of life, there are also issues that come in. So I find that throughout the continuum of care, palliative care is needed and it's important to address the issues that arise. So looking at the Kenya's constitutional framework, which support palliative care, there are many of them, but I've mentioned a few. So we have the 2014 World Health Assembly that has roles for governments on strengthening intervention of palliative care services. We have the Global Action for Control of NCDs, where cancer also falls in. We have the Sustainable Development Goals and the much spoken about universal health coverage, and also the Healthcare Act and many other policy documents that support palliative care. And then when you narrow to cancer, we have the National Cancer Control Strategy for 2017 to 2022. And when you look at Pillar 3 there, we see palliative care is represented, and it's there to improve the quality of life of those living, recovering from, and dying of cancer, and throughout their life and even through support and rehabilitation. Also, when you look at the Kenya Cancer Policy that was launched for 2019 and 2030, it also has the objectives, and you can see the main objective of this policy also includes palliative care as one of the key items to follow up. So based on this framework and many others, so we ask, why do you have to develop the palliative care policy? Why? And the answer is because there was a need for palliative care. As Dr. Zipora has mentioned that as Kenya, we started from building evidence. We had service delivery, we've been providing services. And throughout this period, we noted that a very small number was receiving palliative care. This was 2018 data, which was 3%. And there was also a poor total pain management. There's also a gap in education. You'll find people who are trained in palliative care did not have a proper scope of work. There was no way of remuneration. And when you go to service provision, the standards of palliative care, the recognition, and even the research and evidence of palliative care was lacking, or it was not in a stratified manner. So the palliative care policy was brought to guide the development and the components necessary to ensure provision of palliative care for all. So when you look at the palliative care development, how was it developed? So the first step was evidence gathering, and this was done in 2018 when the Kenya Health Facility Survey was conducted to identify gaps in palliative care service provision, and many gaps were noted, which report can be shared. And this was made possible because service provision had started a long time ago, and there was plenty of evidence that supported the issue that I just mentioned in the past slide. And then after the gaps were developed, there was stakeholder analysis where the needs were identified as SWOT analysis. And this led to building coalition, which will support the development and the drafting of the policy. So it was led by the Ministry of Health through the National Cancer Control Program with KEPCA and other partners. So the policy was drafted working with a group of experts through different meetings, reviewing and viewing the policy, and then follow-up approval process by the Ministry of Health. So I'll very quickly go through the policy, the components of the policy. So the policy is for 2021 to 2030, and the vision is to have a Kenyan population with access to quality palliative care services. The mission is there to ensure that we have provision of timely, culturally appropriate, and I want to stress that culturally appropriate, some care that is appropriate and is acceptable by other people, evidence-based and holistic. And then the goal is to enhance palliative care services in Kenya by guaranteeing equitable access to quality services. I also want to underline equitable. So whether someone is in the village or someone is in Nairobi, they should have access to this service, whether they have money or not. So the policy has 7 pillars. So the first 3 include advocacy and communication to promote access to information. Then you have leadership and governance, which ensures strategic frameworks exist with the proper coordination, oversight, and accountability. We also have service delivery, which ensure access to holistic and culturally appropriate palliative care services at all levels. The fourth one is availability and access to essential medicines and commodities. We've heard many times people with cancer mentioning they have shortages of colostomy bags and prosthesis and the rest. So this policy links to cancer care by supporting the availability of these commodities. Then you have human resource and education, ensuring that we have adequate, skilled, and motivated health workforce to support palliative care services. And then also the health information system and research. We know that without information, without documentation, if we don't have enough evidence, then we find that it affects the development of palliative care. So we ensure that creates the evidence base for palliative care and reporting and quality information. And then we also have healthcare financing, which most of us have talked about universal health coverage. There's a lot of discussion along national health insurance funds to ensure that anyone who needs palliative care at any point, they can get it despite their financial status. And then there are also some other key considerations apart from the pillars. So we have considerations about end of life care, a lot of discussions on where can someone die, what needs. That's where discussions about also advanced directives. When does someone give advanced directives like do not resuscitate? Should I be resuscitated? Should I take chemotherapy when I'm on stage 4 cancer, and such discussions? Then you have survivorship, and that's the main reason why we're even holding the World Cancer Day tomorrow, to make sure that it's identified early so that the treatable cancers can be treated, and we increase the survival rate of our people, as well as looking at special populations like the children, people in prisons, and the rest who still need palliative care. And then we also this policy is going to be implemented by many stakeholders. So we have the people with living palliative care needs, the public, Ministry of Health, and other ministries, because the Ministry of Finance will provide the funding of education supports in education and awareness, and especially the county governments, because part of the health is devolved and they are very key in supporting implementation of activities, creating space for palliative care, and even allocating healthcare workers to their units as well. We also have the training institutions and the regulatory bodies, which will support in setting up the standards, accreditation of sites to be palliative care units, and even NHIF accredited facilities. And then you have the civil societies and the health development partners who support in funding and advocacy to ensure that the rights of people with palliative care needs is upheld and no one is left behind. And the palliative care providers, who are the majority and the key people in the service who take care of people with palliative care needs every day. But also, we don't leave out the complementary and the alternative service people, because these are the people, the popular sector and the ethnomedical sector, where many people listen to before they come to the facility. So we look at ensuring that they're involved in the correct way to support partners, as well as the media houses and even other partners like the legal fraternity who support palliative care. So all the stakeholders are involved in the implementations of this policy. So next steps for this is to continue the dissemination of the palliative policy. We're working with the National Cancer Control Program. They are leading the dissemination, and we've done one dissemination with the Western region in Kisumu. There are other dissemination planned in the other regions, like the Eastern region, the Coastal region, and we'll request all the members to participate who are able to participate and know what the policy talks about. And then we are looking at updating the palliative care guidelines and standards in line with the new WHO guidelines and in line with the policy, and advocacy for country allocation of resources to implement the policy. So in conclusion, the key points is the first one is palliative care approach benefits all people living with life-threatening conditions, including cancer. Palliative care begins at diagnosis through to end of life and bereavement. The stakeholder involvement is essential for development and implementation of a policy, any policy, including the palliative care policy. And then the palliative care policy provides an enabling framework for palliative care implementation and development. And last but not least, I just want to stress that hospices provide key interventions in the continuum of palliative care, including cancer care. Thank you for listening.
Thank you very much, Michael. That was very extensive and thought-provoking. And I'm sure those who might not have a policy in this meeting will be thinking about consulting KEPCA for technical advice on how to go about getting a policy, a palliative care policy for your country. I think even the key consideration issues that we had mentioned in the policy but did not expound on are very important, because I spent, I think, almost 2 hours today on phone with a family that I don't even know, where the mother is a 62-year-old lady with cancer of the rectum, with mets to the lungs, and she wants to continue having treatment, chemotherapy. The doctor has prescribed chemotherapy, but the children were like, no, we should just make her comfortable and watch her die. And these are very difficult ethical dilemmas that usually sometimes we face as palliative care providers. At the end of the day, it's what the patient usually wants that matters. So I think we will probably work to improve on to really have like ethical committees that can support families and patients make such decisions in our key considerations. Thank you very much. And so now we'll go to our next speaker, Dr. Manuel Lurica, who is the Executive Director of African Palliative Care Association. Makilan worked with Dr. Emmanuel for many years, so having a very good presentation shows she had a very good boss who was mentoring her. And Dr. Emmanuel, I think, I don't remember if it was 2016 when you came to Kenya when we were talking about the policy. We went together to the Ministry of Health and met our head of departments, NCD department and other departments, to talk about the importance of having a policy. So I really believe that your visit to our Ministry of Health as the director of the regional office influenced the ministry to say, yes, let's now work on a policy. So I want to thank you for that. And I'm handing over to you to do your presentation. I don't know if you're on. Is it Dr. Manuel, is he on?
Yes, thank you very much.
Yes.
Dr. Zippy, can you hear me clearly?
I can hear you. Can everybody hear Dr. Manuel? We can't. Are you the one who's connecting to audio? No. We can't see you though.
Yes. Hello.
Yes, we can hear you.
Thank you very much. Thank you very much, Dr. Zippy, and thank you very much, everybody, for joining the session. I had a very unfortunate incident today where I had to go and sort out an urgent issue with a family member. So where I am, making my presentation from a moving vehicle, and I'm not able to share my screen, but I hope I'll be able to share the slides so that Mishka can share them with everybody who is on the call. In terms of the
Emmanuel, we've lost you.
Zippy has a lot in a very, not in Kenya, we've been involved in over 10 countries now in helping them to develop palliative care policies, and these include Zimbabwe, Rwanda, Tanzania, Eswatini or Swaziland, Botswana, Zambia, Malawi, Tanzania, and a couple of others. But just to highlight how that translation has happened, when we were developing the policy in Botswana, their Ministry of Health requested that we include a section that allows the government to support hospices where there are no government services to provide the same service. And Botswana, there are two countries that have done that in Africa at the moment. It's Botswana and Uganda. Uganda has also expanded support to non-government hospices, supporting them in terms of funding, but also in terms of providing the various other requirements for delivery of palliative care. In terms of human resource for palliative care, again, we have a number of countries that have done that, that have ensured that we have dedicated training programs for palliative care. Malawi is one of them. Uganda is one of them. And though Uganda doesn't have a standalone palliative care policy, its implementation is drawn from the health sector strategic plan, as well as the other cancer-related and palliative care-related policies that focus on that. Then we have countries like Rwanda. Rwanda,
You've lost you, Emmanuel.
which was the first country to introduce a palliative care policy, and they have also invested when they are needed. Again, because of that, we have Uganda, we have Rwanda, we have Botswana that have access to those medicines. There's another country that I'll mention, which is Seychelles. Seychelles does not have a standalone palliative care policy, but their cancer policy covers palliative care, and they have made medicines available. When visiting their facilities 2 years ago, we found that even in their units, the medicines available, What they lack is access to radiotherapy, which is available outside outside the country. But for the other countries like Rwanda and Uganda, they have taken it further and availed radiotherapy both as a treatment modality, but also as a palliative care modality. And then you have countries like Eswatini. We supported Eswatini to develop their policy, and then after that worked with them and the Uganda Cancer Institute to set up their cancer, to start setting up a cancer unit so that patients, especially breast cancer of the breast patients who are traveling to South Africa for the treatment. In terms of that, we've also worked with Democratic Republic of Congo, which has palliative care covered in their policy frameworks, but now they are working towards availing medicines. What has been happening in Democratic Republic of Congo is that patients have been buying the medicines. You go, you see a physician, you see a doctor, and then they prescribe for you the medicines, and then you go and look for medicines. For the last 1 year, we've been working with their Ministry of Health together with their Director of Cancer to see the best models to put in place so that their patients can access the services. Their team was in Uganda last year, and they are also working towards making the medicines affordable and accessible by the patients. Apart from that, we have countries that have gone a step further and also developed palliative care as part of the national health system. There is what we, in APCA, we call the Kenya model, where they develop palliative care services within the context of a public hospital. And that model has been wonderfully implemented in Kenya, which we appreciate, but also being expanded in other countries. Now, a country like Uganda has also this in the regional referral hospital by government to provide specialists so that patients can access specialists for palliative care. And that is, again, something that has taken ground, and we hope that other countries will pick from that. The other aspect that is so important in terms of making the services available is making palliative care freely available, or as part of the national health funding facility. Uganda has a model where it's government that pays for the services, pays for the medicines, but we also have the non-government sector. We have models like the hospital-based model in a government facility. You have the NGO facility model, like we have Ginger Hospice. And then you have Hospice Africa Uganda, which is supported by government to produce the morphine and other facilities so that patients can get access to that morphine countrywide free of charge. So those are examples of countries where accessible by the patients. Having said that, we still have a major challenge in Africa, that majority of the patients cannot still reach, get to facilities where they can reach, get palliative care. Even in Uganda, for example, where you think that a lot has happened, where the country is not reaching more than 15%. And they are also yet to extend the service to a home facilities provided at home, are provided by non-government facilities that reach out to the communities and then link with government facilities. So those are gaps which we need to deal with. But in terms of translation of palliative care policy, whether as a standalone policy or palliative care built in other cancer policies, these are examples of countries that have made that progress. Seychelles, Rwanda, Botswana, what has happened in Kenya. We have Tanzania, but even though in Tanzania we also still have a challenge of making sure that, one, as we fight for universal health coverage by 2030, we have to ensure that wherever they put health services, that palliative care is part of that. I want to bring out two very important points that going forward the countries have to address. One, for cancer patients, we know that majority of patients present late. More than 80% in Africa, they present late. And those who need radiotherapy as part of don't have access to radiotherapy. We still have countries where you have to move out of the country to go and get radiotherapy, and yet we know there are some of the services that are needed. For example, palliative care emergencies that need radiotherapy. If you have a spinal cord compression or you have a superior vena cava obstruction, such patients suffer unnecessarily because those services are not available. Secondly, we need to ensure that countries make palliative care freely available for everybody without paying for it, because at that time, many of the patients do not have the means to pay for the services they need. Thank you very much. I'll stop there for the moment. I hope that we can discuss that further. Thank you very much.
Thank you very much, Dr. Emmanuel. Despite your challenges, we've been able to listen to you, and also sorry about the family emergency. But thank you so much for sharing about the different countries that have got palliative care policies, whether they're standalone policies or whether they have integrated them into other policies. At least there is a policy that can help them have a national palliative care strategy or framework that they can work with. And thank you for the final points where you talked about the need for palliative care services to be available to everybody for free. It is true that by the time the patients come to see us, they have nothing left. If you are somebody who has been doing home visits, and I've seen colleagues here like Stella Warui and Nasim Mohammed, they will tell you when they go to see a patient at home, they see no sign of fire, no sign of fire because nobody's cooking food because there's no food to cook. They have spent all their money. People have sold their land and everything else. So it drives cancer and other chronic diseases, especially cancer, drive people into poverty because they have spent a lot of their money. Their national insurances might not necessarily cover for all their treatment and diagnostics. So yes, we need to focus on access to all, and that's why even World Cancer Day is talking about closing the gap. One of the gaps is access to palliative care for everybody in need. And I also like the fact that you've talked about, oh, sorry, I have forgotten. I'm so, that's the points you talked about were very important. Yes, the issue of radiotherapy. We need to invest in our cancer care in our countries so that, again, it's still about closing the gaps where we don't have a patient losing the ability to walk or, even die because they didn't get a dose of radiotherapy because of the complications they have received from the cancer. So we still need a lot to do. A policy doesn't mean we have solved our problems. It's just a beginning. Our problems still exist if we don't have the funding to invest in good cancer care, in strong healthcare systems, in UHC, in insurances that protect people. We just have documents on the shelf that will not be of any use. So it is for us as advocates to ensure that these documents bring about change. So we will move to the section on discussions, questions and answers, and I'm opening up this. I would just say that to avoid confusion, if you can just have raise your hand up, use the reactions at the bottom to raise your hand up if you want to ask a question. Then we'll give you an opportunity, or if you want to comment, or if you want to add. It's not just questions, but even any comments, any additions will be welcome. Thank you. I just want to comment, maybe as people are still deciding whether they're going to comment. Dr. Manuel, you talked about hospices being supported by the government. I think that's very important. Most hospices actually are freestanding hospices. Most of them have been started because of a past experience of losing a loved one through very difficult conditions. In Kenya, most of our hospices were started by people who have actually had an experience of a loved one dying without access to palliative care. And so they end up being freestanding institutions which have to look for money, do a lot of fundraising activities and the rest. And the idea that the government should actually take up the hospices as part of their system because they are actually providing services to the country, to the people within their countries is very important. And I know in Kenya, when we started talking to the government, I think in 2002 or something like that, we went to meet with the then director of medical services. I was working at the hospice then, we didn't have the session then. And he was very receptive and came and actually said, can you write a concept note so that I can see what I can do? And we wrote a concept note. And the first thing he did is when he went back to the office, he deployed nurses to the hospices. This was very good because it meant the hospices could now use the money they're paying these nurses to buy drugs and do other things. So there are many ways that the government can actually help hospices. They can give them staff, they can give them, in Kenya, we have some of the hospices that have teamed up with the counties and get their medical supplies from the counties. So again, that is very important that when we talk about palliative care, hospice is part of palliative care. It should be actually supported by our governments. I see a hand up. I don't know which hand is this.
It's me, Dr. Zippy. It's
You,
Mishka.
okay, Mishka.
Hi. Thank you, everyone. Thank you, Makileen and Dr. Manuel, for your talks, and for Dr. Zippy for those great introductory remarks as well. I have a question. It's specifically to Makileen, but I think maybe others also, including Dr. Manuel and others. I welcome your inputs as well. Two questions. Makileen, you mentioned you conducted, as part of the development of the policy in Kenya, a stakeholder analysis and situational analysis. And I'd love to hear more about exactly how that was done, in case that's something that can be replicated elsewhere, so that communities can get to know what the needs are as they're developing policies. And then you also mentioned, as part of the rollout of the policy, was dissemination at the county level. So I'm curious if after dissemination, is there some type of a reporting that happens back in terms of how the policy is implemented in local settings? And if there's like a structure in place, or how that works, and how that sort of maps. You mentioned that it's the National Cancer Control Program that's disseminating. So does that get also mapped into the reporting for the National Cancer Control Program? Sorry, that's two big questions. Thanks.
Okay, thank you so much. I'll start with the second question about dissemination, because that's the most recent. So after the launch of the palliative care policy in October, we worked with the National Cancer Control Program to start with the online virtual disseminations. So we did 3 disseminations in the last year. And then this year, we started the first physical dissemination per region. So we started with the Western region, which was centrally held in Kisumu. And we had more than 11 counties around Kisumu joining, representatives who are seen as key to the implementation of the policy. So members coming from the NCD department in the Ministry of Health and the facilities within the county. So as a way forward, as you mentioned, while this dissemination is happening, so during the meeting, the policy is disseminated, and then discussions are held with these county officials or the participants on the feasibility and maybe the way forward on how they're going to take forward the implementation of the policy, as well as they also are requested when they go back to their facilities, because they're only representatives, to disseminate the policy back to their facilities. So after dissemination, the next step is working with these counties to implement the policies, and also looking at some of the gaps or some of the areas that needs to be supported to be able to implement the policy. So looking at aspects like revising the palliative care guidelines, looking at the standards which can support the sites that already have palliative care units and hospices to develop and have quality standards for palliative care, how to link up with other departments, like for example, palliative care with cancer, and palliative care with other special departments like non-communicable diseases, diabetes, and the rest. So those are the discussions which happen during dissemination. And then, as you rightly said, this is being recorded and documented, because it's a very important aspect which can support and even inform learning for other countries. Thank you.
I can help you respond to the one for the, how did we get the needs assessment? Makileen had not joined KEPCA then, but I just want to say that our government was very good. When they picked up the issue of palliative care, they actually appointed Dr. Eunice Kaditu, a pharmacist who was working with the National Cancer Control Program, and who had been very instrumental in helping us get the central oral morphine constitution project that has been going on for some time now. And she spearheaded a team from KEPCA, from the National Cancer Control Program, to go to hospitals, hospices. We actually developed questionnaires that people would respond to. So we had a set of questionnaires for education, we had questionnaires for service provision, we had others for people living with palliative care needs. And this actually had to inform the gaps and the needs for the policy to address. So there was a system that was used to develop these questionnaires and do the analysis. And then after that is actually when we started working on the actual policy itself now. What do we need to address it from these gaps? What we need to put in this questionnaire? Key stakeholders were also, part of the people that were brought in to give information. So it was a consultative process where we actually went out and found out from those, especially the service providers themselves, people working in hospitals and hospices were able to give us all this information about the needs and gaps, and so that helped a lot in developing the policy. And I also want to say, just in terms of dissemination, recently the Ministry of Health launched a national NCD strategy, and they are just starting to disseminate it. And they've actually decided that as they disseminate this strategy, they'll also disseminate the palliative care strategy alongside this particular strategy, because I think that will actually bring a lot of interest, as most of the patients that are seen in palliative care are actually those living with NCDs. So disseminating those two projects, those two strategies together, one is a strategy and the other is a policy, will probably even reach out to more people than it would have done if it's just a palliative care policy. I don't see any hand up. Anybody else? Nobody wants to know anything, curious, wants to add? Please share your experiences also, those who have got policies in their country.
Hello everyone. Good evening. Thank you very much, Zipporah, for what you are doing. My name is Aquaman. I'm a cervical cancer survivor, and I'm a product of palliative care. And I think palliative care has done a lot for me, because when you are going through certain challenges like illness, and then when you go there, you have a ear to someone to listen to you. So sometimes we take palliative care like our relatives or anyone that you can tell anything. We took palliative care that the place that you can tell them anything. But I think the needs to be done is like maybe from my side, and I stand to be corrected. I think the national insurance should approve the palliative care to use, when you have the illness, you can use the national insurance, so that maybe one day palliative care can become in a big number, because sometimes you find you are living with the patient in your house and you need maybe a week to rest. So if we can have a palliative care like we can take care of a patient for maybe 1 week, and then the relative will be resting for a period of a week before they go back and take the patient to continue the journey, because sometimes it really damages their mind. The caregivers is very hard for them. Thank you.
Thank you very much, Millicent. And I must say, for those of you who don't know Millicent, she's a great advocate. She speaks about her condition, and recently she even shared that when she was told she had cervical cancer, she wanted to kill herself and her children. But I'm sure because of the services she received from the hospice, who did a lot of counseling, from other people like Benda, I can see here, those people who support patients, Women for Cancer and the rest, she was able to get treatment, and now she's managing her life and has become actually a great advocate. Millicent, I hear you. I think Makilin can also answer that. They're trying as much as possible. And I know personally, I've met with the CEO of NHIF, I think last year or the other year, twice, to advocate for palliative care to be included in the NHIF package, including home visits. It's not easy. We haven't seen what they've come up with, but we are hoping that they can include it. And I can understand when you talk about respite care, the hospices in this country have what you call daycare, where the patient is brought to the hospice and spends the whole day there. And the family members can now do other things. They can go to the bank, they can go do shopping, they can rest, they can go to the salon and have their nails. But it's only one day in a week, and not all of them are able to afford this. It's mostly sponsored by the community, who bring in food for the patients and who come and spend time with the patients. It's true that we need maybe a center where we can actually have patients maybe rest also from the family, and the family rest from the patients. So Makilan, I hope you are noting these suggestions that KEPCA can actually look forward to working on. And if you want to add anything, Makilan, please go ahead.
Yes, thank you, Dr. Zippy. just to add to what you've talked about, respite care and support to caregivers. One of the roles of hospices is having a model. They usually have the home-based care model where they see patients at home, but they also have the daycare model where at 1 day in a week or 2 days in a week, you find caregivers can bring their patients to the hospice who can have like a support group they share, while the caregivers can go and undertake other errands and the rest from that. So I think one of the key advocacy points that we could look at even as cancer stakeholders is advocating for hospices to have NHIF, because currently hospices are not accredited to get NHIF because of many reasons. One of them is because they do not fit in the criteria, the NHIF criteria for them to be accredited. But if you look at the role that they support, it's quite huge. So the home visits, taking care of the patients who are at home, who are not able to come to hospital, or they're on supportive care there, which can be given at home, it's very important. So one of the things that we are looking at as KEPCA is looking at evidence that supports home-based care or home care as an equally valid setting of care, and looking at the gaps which NHIF has been saying because against covering home care and home-based care as part of NHIF. So we hope when you have that breakthrough, it will be a very important one, because it will support hospices and other facilities and CB community-based organizations that take care of people with cancer and other people at home, as well as respite care. So those daycare centers and areas where people can take their patients for a day or two, or even for 3 days as they work on other errands. It will be a big breakthrough, and we call all the stakeholders to support us on this. When we call upon you, maybe with information or in advocacy or visiting NHIF and all the other people who are concerned to support that. Thank you.
Thank you, Michael. Brenda has asked a question here. Kenya has truly achieved much in the field of palliative care at Zippy, but I want to say at Emmanuel. Is Emmanuel still with us or he left? Yes, what advice would you give advocates on the call for things to watch out for when engaging the government and policy makers to cascade both palliative care as well as other policies? I'm giving this to Emmanuel because you have worked with different governments. I can talk about our government, but you work with different governments in Africa, and so you know probably what are the long-hanging fruits and what are the things that we need to do to engage the government to support palliative care and other policies.
Okay, thank you very much, Zippy. One of the things that has worked for us is, first of all, look out where it has worked, and then introduce the other countries which you are targeting to the same. That's one. Number two, understand the setup of your government and use people who have benefited from palliative care to access one of the key people in government. And when you get into government, you need to strategize for the Ministry of Health, of course, that is one of them. You need to strategize for the Ministry of Finance, because they are the ones who give the budgets after all. You have the parliament. So in Namibia, in Uganda, in Rwanda, we've had an opportunity at one stage to meet members of parliament and interest them in the issue of palliative care. And so it is important for you to understand your government very well and then target them by level. You need to focus at the arms of government, the executive arm, including the minister, and if necessary, the
Thank you very much. Are you still on? We've lost you. Dr. Emmanuel, are you still there?
And then also
We've lost you. Okay, let me just add also, I think, Brenda, you need to be bold, and I think you know about boldness, Brenda. You need to be stubborn, you need to be diplomatic, and you need to tell them, I want to talk to you, I want to make a presentation. That's what it took for the government to say, let's integrate palliative care into this country. I was actually asked for a session with the heads of departments, the Ministry of Health, and given 15 minutes to tell them, and you have to use cases, real people cases, because they need to see the suffering. Those 1 minute elevator speeches become very important. So again, case studies, working with people living with those conditions, people who are in need of palliative care in the forefront of their own advocacy is very important. But Dr. Emmanuel has said, understand how your government works. For us also, it took bringing in the two ministers who had cancer to agree that it was important to have palliative care. And also the cancer bill also helped. So again, look for opportunities. Is there somebody who has a relative with cancer in that ministry? Is there somebody who is going through cancer treatment? Don't miss those opportunities, because at that time they are the weakest and vulnerable, and they're able to support your initiatives. We have maybe like 2 more minutes left for questions before we hand over to Charles and Mishka to give us. I don't know if Dr. Our chair, is she in? I'm not seeing her name here.
Yes, she is. Dr. Mark is here.
Oh, okay. Yes. Yeah. Oh, okay. My screen is small. So if she'd also like to say something.
Sorry, do you mean the chair of Kenko?
No, not the chair of Kenko. The chair of Kenko is not in. I meant the chair of this ECHO. Is the chair of Kenko in? She can also say something if she wants to. I don't see Daktari on the screen. And I think she was in at one time. Amaka, are you still there? Dr. Amaka?
Yes, I am. It's just that my network is choppy.
Oh, okay. Because I'm trying to look for you. Can't see. But you'd like to say something, then Mishka can say something, and then Charles can give us some announcements. Because I don't see any more questions.
Yes, just to say that I really enjoyed this session, the presentation, and like I'd mentioned during the planning phase, in Nigeria, we also just recently launched our palliative care policy. So it's good to see what you're doing, and definitely there are quite a few things that I personally have learned and we can put to use for our own policy integration and implementation at the various levels. So thank you to all our speakers. It was really great to hear from you, all the great work that is being done in Kenya. Yeah, back to you, Zippy.
Thank you. Thank you. Mishka, anything you want to say before we thank our speakers, or you can thank them on our behalf, since you're the main, the backbone of this whole ECHO thing?
I don't know about the backbone, but yes, I do want to take the opportunity to thank you, Dr. Zippy, for designing this excellent session, and to Makilene and Dr. Manuel for your presentations. And thank you all for the questions and comments throughout. And a special thanks to Millicent for sharing your experience, and please keep sharing what we can be doing at a systemic level to continue to be working in partnership with you and other patients and survivors as the key voice and the key reason why everyone's doing this work. So thank you very much for your story and for everyone being here. Back to you, Amaka. I see you raised your hand, and then we'll let you and Charles close out.
Yes, thank you, Mr. I just wanted to let everybody know that we've gotten a YouTube channel. So for those that missed this really fantastic talk, and for your colleagues that you want to encourage to listen in, the YouTube channel is now live. And so all of our recordings will now be posted on the YouTube channel. So everybody can go back and listen to it as much as possible. It's great content that has been shared here. So thank you. I think, Charles, you will perhaps put the name of the YouTube channel in the chat box. So everybody.
All right. Thank you very much, everybody. I just want to say thank you so much to Makilene and Dr. Manuel for taking time to present in this session. Thank you, Mishka, Charles, our chair, Amaka, and everybody else who has attended.
What it is. But that's just the announcement. Thank you.
Sorry. You're still speaking. Yeah. Okay, Brenda, I have put a link for the publication that just came out 2 days ago that we worked on that talks about how we have had palliative care in Kenya develop over time. So you can actually access that publication on that link. It just came out, I think, 2 days ago. And also, Brenda would like to inform us that she will be speaking tomorrow in the World Cancer Day celebration by WHO. Brenda, is it by WHO?
It's the UICC, Union for International Cancer Control.
UICC. Yes. So you can share with Charles the link, because Charles has access to everybody on this call. He will share it to them. So let's support Brenda tomorrow when she's presenting. Charles, do you have announcements to make?
Yeah, I think most of the things have been said, but just to thank everybody for participating in our meeting today. So as Amaka has said, we are going to share the recording after this. We are going to share the link to our YouTube channel, where we will post a video on Basecamp. And if you are not on Basecamp, you can reach out to us so that we can add you to that network. Then just to remind everybody that our next session will be held on February 17th. That is 2 weeks from now, and we are going to be focusing on implementation science, strategies and frameworks, and how they can use resources in the developing world. So please plan to join us then, same time, and we are going to learn a lot more together. Otherwise, thank you very much for joining us today, and have a good time. Thank you.
Yes, and please invite others. We want to as many people as possible to attend these sessions. They are very useful. They are for us. They will help us improve our practice, also help our patients to become better advocates. So please invite other people to join these sessions whenever you can. When you receive it, invite others as well. Thank you. Are you done?
Thank you, everybody. All right. Goodbye. Take care.
Thank you. Everybody, goodbye.
Bye. Bye, everyone. Thank you, Zippy.